Hello, so I'll be talking just about the classification of lung cancer. The basic classification that it is divided into small cell lung cancers and non-small cell lung cancers. Small cell lung cancer constitute about 15%, which is lesser compared to the non-small cell, which is about 85%. Now, the further classification is the small cell, non-small cells are classified into adeno, squamous, and large cell and bronchial carcinoid type, among which adeno constitutes about 40%, squamous about 30%, large cell 10%, and bronchial carcinoma around 5%. Now, just a little bit of future. Small cell lung carcinoma is also called as oat cell carcinoma. A few features about small cell lung carcinoma. You can remember it as with the word with the letter S. So S for smokers. So it is seen in smoker. S is central in region. Just remember it as C or S. It is central. Whereas non-small cell, among most of the non-small cells, are peripheral in nature. So small cell or central, and this secretes ACTH, ADH, and antibodies. So I'll be telling about that. ACTH causes Cushing syndrome, and ADH causes SIDH, and antibodies against presynaptic calcium channels causes Lambert-Eaton myasthenic syndrome. And don't mind the word, but it sucks to be having a small cell in the sense compared to the others, because it has it is very aggressive, and it presents with early metastasis, so it has poor prognosis. Or you can also remember S for SIADH, and M is it is associated with MYC gene amplification. A is ADH increase or ACTH secretion. L for Lambert-Eaton syndrome, lung carcinoma. So if you can remember, just shortly I'm telling, smokers, central, and it secretes these things, and it sucks to be having this. And I'll be telling a little bit basic differences between all of these. So yeah, smoking, as I said, small cell lung carcinoma, they are associated in smokers, adeno in non-smokers, squamous is seen in smokers, large cell is also seen in smokers, bronchial carcinoid we do not have information about that as such. Location wise, it is small cell is central, and adeno is peripheral in location. Squamous is again central, large cell is peripheral, and bronchial or carcinoid is not specific to the location. Coming to histopath findings, you will find in small cell lung carcinoma, you will find this azopardi effect, which is the basophilic staining of the vasculature, and also salt and pepper appearance. In adenocarcinoma, it's the lipidic pattern, where you can see also butterfly on fence appearance, and in squamous, its classical is keratin pearls. Large cell, I do not have the picture, and it is associated with poor prognosis. Bronchial carcinoid as a better prognosis, which will have neuroendocrine cells. Now, next, or basically, I'll just be telling the differences between small adeno and squamous. IHC is related to small or synaptophysin, chromogranin, bombesin, and NSE, neuron specific enolase. And in adeno, we have napsin A, mucin 1, TTF1. In squamous, we have P40 and P63. In genetic wise, as I said, the mnemonic small m you can remember as MYC. So it is associated with L-MYC gene amplification, also loss of 3p. And in adeno, it is associated with ALK, KRAS, and EGFR1 mutations, and in squamous, it's P53 mutations. Coming to paraneoplastic syndromes associated, as I said, ACTH causes Cushing syndrome, ADH, SIADH, that is, and Lambert-Eaton syndrome caused by the antibodies against the presynaptic calcium channels, Lambert-Eaton myasthenic syndrome. And with adeno, we have migratory thrombophlebitis and hypertrophic pulmonary osteopathy. And with the release of PTH-RP in squamous, we have hypercalcemia seen as a paraneoplastic. In large cell, we have gynecomastia, and in in carcinoid syndrome in bronchial carcinoma. So this is just a bit basic about the lung carcinoma.